Hello everyone, this is Sharik Shamim. I have no financial conflict of interest regarding current talk, but I do have several intellectual conflicts. If we attended New York reunion, Dr. Jagat Nurullah had provided a pretty insightful idea about atherosclerosis in humans. We have been getting atherosclerosis from ancient civilization, including mummies when they were scanned with a CAT scan, and coronary artery atherosclerosis evidence was found in them. Does it matter if we die with pristine coronary arteries like these, or we die with advanced atherosclerosis when we have lived our life, what we felt was a fulfilled life? Most people tell me latter is more important for them than the former. The data is very clear. Atherosclerotic coronary artery disease remains one of the leading cause of mortality across the world. In some areas, prevalence is quite high compared to other areas. In recent years, we are seeing large number of premature death from MI from Indian subcontinent. It is a fact that we will all die one day. Older we get, higher is the risk of death. And nobody is surprised that if you have death in this age group, and the leading cause of death remains cardiovascular disease. But when we die in this age group prematurely from premature atherosclerosis, that's what causes trouble to most people. Nobody will be surprised if we die of heart attack in this age group. But this age group, where we are in most productive time year of our life, we have family obligations, and premature death in that category hurts. So let's look at the data for the risk factor for coronary artery disease. When we talk about CAD, atherosclerosis, we all almost universally think about LDL. But let's look at this data, 21-year-old follow-up women's health study, and look at the hazard ratio. Having type 2 diabetes has almost 11 times higher risk of having atherosclerosis, coronary artery disease. And high LDL is only 1.4 hazard ratio, just 1.4 times higher risk. But look at this metabolic syndrome, which we Indian get at even much lower BMI compared to Western people, 6 times higher risk. Hypertension, we all know. Obesity, smoking, we all know. Family history, we all know. But hazard ratio is dramatically higher when we have metabolic syndrome and type 2 diabetes. We all know that high LDL is bad, but just 1.4 hazard ratio as compared to lipoprotein insulin resistance, which has hazard ratio of almost 6.5. But neither we check it nor we treat it. But we'll talk more about this a little bit later, so keep this slide in mind. That was the data largely from Caucasian females, but we're more interested in Asian Indians. Us, we are having a lot of premature atherosclerosis. So this is an interesting study called coronary artery disease among Asian Indian. Blue graph is Framingham offspring. As we know, Framingham heart study was one of the important study that was able to give us pretty tremendous insight about what causes atherosclerosis. The study was started in 1948 in Framingham, Massachusetts. Most of the people in that cohort are offspring from European population. So that data may not be applicable to us. But unfortunately, most guidelines are based on Framingham offspring study. And we, as Indians, have been following them blindly, which is very unfortunate given number of high academic people from Indian origin or India are in American universities. Red is Asian Indians, that's us. We don't smoke as much compared to Framingham offsprings. Obesity is lower in terms of absolute BMI, which may be due to BMI criteria for obesity of Framingham cohort. As we know, Asians should have much lower BMI for obesity definition. We have less hypertension, our total cholesterol is lower, our LDL higher than 160 is also lower than Framingham offspring. But what do we have, which is very well known to most of us, is we get low HDL, high triglyceride, and markedly higher diabetes compared to Framingham offspring. And we knew from the first slide that diabetes is a major risk factor for atherosclerosis. I think this is a very interesting slide that some of you may already know from the data I had shared on AFMC groups. Let's focus on men category first. 3 ethnicities, diabetes prevalence depending on BMI. Look at this. This is striking. At BMI 19, almost 8% of East Asians, or us Indians actually, are getting diabetes. In females, almost 9% females are getting diabetes at BMI 18. There's a sharp increase in diabetes risk as the BMI increases, both in males and females. This is dramatically higher incidence compared to Europeans on the red line versus other Asians, Japanese, and Chinese. And most guidelines, when they talk about the BMI in the old guidelines, used to be the cutoff for 25, largely coming from Caucasian data, because Caucasian were not getting much diseases up to BMI 25, and after BMI 25, they were getting diabetes, hypertension, other diseases. But us Indians are getting these diseases at much lower BMI. And at BMI 30, almost 1 in 4 Indian men are getting diabetes. And similarly, at BMI 30, almost 1 in 5 females are getting diabetes. And we all know diabetes or pre-diabetes or insulin resistance is pretty bad to have in terms of risk factor for atherosclerotic coronary artery disease. This was another interesting snippet from Lancet, published more than 20 years ago. 2 people, John here and Yajnik here, identical BMI of 22.3, but they went under DEXA scan. Look at the difference in body fat percentage. This person has 9% body fat and this person has 21% body fat. Could this be responsible for diabetes incidence that we get at much lower BMI? And could this be the culprit for atherogenic dyslipidemia or lipoprotein insulin resistance that we get? Can we blame all this to genetics, or could the lifestyle may be relevant here? One of these authors runs marathon, and the another author, all that person does is, uses the elevator in the hospital every morning and closes the door. So is it all genetics, or is it chosen lifestyle? The answer is pretty obvious. We all know as a physicians that metabolic syndrome is pretty bad. People with metabolic syndrome can get much more aggressive form of atherosclerosis, more common to have severe disease that are not possible to revascularize either by CABG or PCI with distal vasculature involved. And the metabolic syndrome is quite common actually. Many people who have low HDL, high triglyceride, and fasting sugar just more than 100. And by the way, you can wear a continuous glucose monitor even if you feel healthy and see how numbers running. You may be surprised. And not just fasting sugar, more data is available that even in people who are completely healthy, all labs are normal, if they get postprandial hyperglycemia with blood sugar going more than 140, which CGM can show you, are more likely to develop atherosclerosis, even though all the lab work is going to be normal. Anyway, let's go back to metabolic syndrome, abdominal obesity, and hypertension. So this is all completely linked. We call it metabolic syndrome, but we know from pathophysiology, all of this is linked to one problem, which is insulin resistance. We should not be thinking of insulin resistance in terms of type 2 diabetes. decades before type 2 diabetes develop, we can have pre-diabetes, or before pre-diabetes, we can have insulin resistance. And insulin resistance itself is causing atherosclerosis that is being missed. So we have missed decades of prevention if we largely focus on end outcome of insulin resistance. We need to be screening for insulin resistance early, and we should work on fixing it. It's very easy to fix insulin resistance if we find it early. Only 3 criteria is needed out of these to have official definition of metabolic syndrome, and I can tell you half of the audience may have this. And you can read more about this, go to this paper and understand how it leads to the trouble, including fatty liver. People who have high triglyceride or low HDL, we can assume they have metabolic syndrome, even though they may not be meeting other criteria. I think in order to understand atherosclerosis, we should go back to first year of medical school. And probably almost all of us have forgotten this, but as you know, vascular wall has 3 layers: intima, media, and adventitia. And endothelium, that single layer, I think this is the most beautiful cells we have in the body. They have remarkable functions inside the body that most of us simply ignore, or maybe we do not know much. Based on current data, it is the endothelial dysfunction which is the precursor of atherosclerosis. So if we need to keep one thing healthy to not get atherosclerosis, is keep the endothelium healthy. And we'll talk about it. And let's go back to second year medical school and understand data from Robbins. Although this is from a well-published paper, somehow my reference is hidden here, but I hope you can see it. So we get fatty streak very, very early in life. Even like first decade of life or second decade of life, we can get fatty streaks. And then we have pre-atheroma, then we have atherosclerosis, and then complicated plaque and plaque rupture that eventually causes MI. What is interesting is we used to get this by fifth decade of life, sixth decade of life. We used to have MI in 60s and 70s die. But the problem is nowadays even kids are developing this prematurely, which is very sad. And as you see, as the atherosclerosis progresses, endothelial's capacity to generate nitric oxide keeps on decreasing. So more atherosclerosis we have, less endogenous nitric oxide production is possible. This is a beautiful animation created by my friend Jay Mohan, who is an interventional cardiologist. This demonstrates how MI or heart attack happens. So the plaque will progress, and thin cap fibrous atheroma, which is defined by 65 micron or less cap thickness. So the plaque has a cap, that lining you see. If this is thin cap, that it cannot contain all this atheromatous thrombogenic materials, and the plaque ruptures right there. This exposes thrombogenic material into the lumen of the vessel, and similar mechanism, as we get a scratch on the skin, the blood will come out and thrombus has to form to stop this. Similar mechanism has to happen here. So thrombus is going to form, and if thrombus propagates and occlude the vessel completely, that leads to MI. And if this happens in younger people who are not used to ischemia, ventricular fibrillation can happen, and you see all of a sudden people are dead, and they cannot be revived unless CPR is initiated and they are defibrillated out of ventricular fibrillation quickly. Whenever we talk about atherosclerosis, first thing comes in mind is LDL, which is true because you have to have LDL particle in order to have atherosclerosis to take place, but LDL is just a bystander molecule. It is not there to kill humans, unlike what us cardiologists believe, that only function of LDL is to kill humans. As we saw from very first slide, lipoprotein insulin resistance is 6.5 times odds ratio compared to just elevated LDL of more than 160 or 190. And newer data is coming, maybe high LPA level is independent risk factor for atherosclerosis. We should really revisit function of LDL and how LDL going to the place where it does not belong may be the precursor for atherosclerosis actually. So contrary to what we have been programmed to think LDL is there to kill us, LDL has an important function. It is to deliver the cholesterol from liver to the end organ. Or membranes, cell membranes are phospholipids. Lipids needs to go there. Brain has so much of lipid content. So receptor-mediated endocytosis of LDL is a normal physiological process. It is taken over by a receptor, deliver the free cholesterol, and it's supposed to leave. However, if LDL goes into subintimal space where it does not belong, see these endothelial cells? They have junction. These junctions are so small that they cannot let LDL to pass through it. But if we have endothelial dysfunction or injury to endothelial cell, that these spaces are more open, then LDL will incorrectly gain the entry to subintimal space where it does not belong. And in the body, if we get any particle that does not belong in the bloodstream, macrophages will try to engulf it, be it virus, bacteria. Similarly, now the LDL has gained entry into subintimal space where it does not belong, is going to get oxidized. And when it gets oxidized, that will initiate the cascade of events that the macrophages, they're very big. They cannot penetrate these junctions. They have to change the form in order to gain the entry there. This is all pathological process happening. What was the initiating part for this is the gap between endothelial cell which led LDL particle to go down. This is critical to understand, and this is why I mentioned in the initial presentation that the initiation of atherosclerosis is endothelial dysfunction, not necessarily LDL. Although LDL is needed to have all this mechanism to create a foam cell. So now macrophage is going to come here, change the shape, engulf the oxidized LDL, and that's how the foam cell is formed. Congratulations, you're having pre-atherosclerosis and atherosclerosis now. Again, what is the mechanism this is happening? Endothelial dysfunction, injury to endothelial cell, that the native LDL that was supposed to do this function is not only doing this function, is going to incorrect place that needs to be eaten up by this mechanism. This is how atherosclerosis starts. And don't be surprised in some people who have very high LDL, because they had excellent endothelial cell function, they never develop atherosclerosis. I have several patients in my clinic whose LDL lifelong has been 200, 250. They decline statin, and when we do coronary CT or calcium score is 0, no plaque at all, because somehow they maintain good endothelial health. So as we learned from previous slide, that it is the endothelial dysfunction and injury of endothelial cell, which is the precursor of atherosclerosis. And mechanistically, it may not be possible to have atherosclerosis without endothelial dysfunction. So what causes endothelial dysfunction? Let's revisit this so we can do things to prevent that from happening. Hyperinsulinemia by itself leads to endothelial dysfunction. It is very well published. Hyperinsulinemia itself increases risk of MI. Again, very well published. We never check fasting insulin level. We don't do anything about it. But guidelines indirectly recommend like lifestyle diet changes, but do not address this. And as a physician, we do not check it. We know that diabetes is very bad. I mean, we saw from very first few slides that odds ratio of almost 11. And so many of us get diabetes prematurely at very low BMI that we also revisited. And I feel sad that diabetes is a totally preventable medical problem. Even if we develop diabetes, we can reverse it, but our focus remains on pharmaceutical approaches. Anyway, let's go back to the topic that I'm discussing today. Hypertension itself causes endothelial dysfunction. More higher the pressure, the more is the endothelial injury. Atherogenic dyslipidemia causes severe endothelial dysfunction. Smoking causes severe endothelial dysfunction. Metabolic syndrome, as we saw earlier, is very well published to cause severe endothelial dysfunction. Obesity itself causes endothelial dysfunction, and sedentary lifestyle causes endothelial dysfunction. If we check fasting insulin level, we are hyperinsulinemic. Obviously, we should be setting our goal to be highly insulin sensitive. It is interesting to notice that based on current literature, Indians get insulinopenic insulin resistance. I mean, traditionally in Western population and other racial ethnicity, they get insulin resistance at very high insulin level. And Indians generally get insulin resistance at very low level of fasting hyperinsulinemia. If you're highly insulin sensitive, there's no way you can get type 2 diabetes. And interestingly, when the hyperinsulinemia is corrected, a lot of people's high blood pressure becomes normal because hyperinsulinemia causes endothelial dysfunction. Endothelial dysfunction leads to less nitric oxide production, and that leads to vasoconstriction. Well, we should keep our HDL normal and low triglyceride. And when I visit data sent to me from friends, family from India, all I see is low HDL, high triglyceride. And unfortunately, so many of us have been told this is normal for us. In fact, I personally had this when I was first year resident, and I was told by a very famous preventive cardiologist that this is all normal, don't worry about it, your LDL is normal. Obviously, we cannot emphasize enough, smoking is not good, and unfortunately, so many of us are getting almost secondhand smoke. Like data was published in New Delhi, it is smoking the regular air is similar to smoking 10 to 20 cigarettes. Obviously, that's causing endothelial dysfunction. And we get metabolic syndrome. Root cause for that is also insulin resistance. BMI of 23 is abnormal for Indians. However, based on looking at the data and some other studies, I would think that at BMI 20.5, many of us start getting severe metabolic dysfunction. And obviously, if it is very difficult to keep BMI 20 less than 20, but BMI can be higher, obviously, if you exercise and if you have more muscle. But we saw from previous data, YY paradox, identical BMI, certain people having much lower body fat compared to us, largely due to our lifestyle. And moderate daily physical activity, which is 30 minutes of brisk walking daily, is recommended, that most of us do not get. Let's touch base on atherogenic dyslipidemia, because most of the Indians are plagued with this. This is very unfortunate. So we may not be getting high LDL, unlike Western population. Our LDL is largely normal because of the low fat vegetarian diet that most of us follow. But we have high triglyceride, low HDL, and this is known as atherogenic dyslipidemia. As the name says, atherosclerosis forming lipid disorder. A root cause for that is, again, insulin resistance. So if you fix your insulin resistance, your lifelong low HDL which is less than 40 for males, may become completely normal. So I personally gave you my example. I had low HDL. No matter what I did, exercise, running, 5K running every day, my HDL will not improve. However, once I fixed my insulin resistance, my HDL went to mid 40s. And we'll revisit in the talk a little bit later is how we can fix insulin resistance. If we do advanced lipoprotein analysis, NMR lipoprotein analysis, it also gives us lipoprotein pattern. Lipoprotein pattern B is really bad. In fact, if you have lipoprotein pattern B and all the other labs are normal, the question is when you'll get diabetes, not if you will get diabetes. It is inevitable you're going to get diabetes. In fact, there have been published papers that show that lipoprotein pattern B predict onset of type 2 diabetes 10 to 15 years before diabetes will develop in individuals. And as we discussed in the very first slide, that even if you have atherosclerosis and we lived a normal life, it does not matter. But dying prematurely from atherosclerosis is what we all worry about. And let's focus on this important paper published in Circ many years ago, but largely ignored. Let's focus on this. So based on triglyceride to HDL ratio, 4 quartiles were created in this paper. If your triglycerides to HDL is 1 to 1, which is, I'm not aware of many Indians who have it, that's a reference. And triglyceride to HDL ratio more than 5:1 is 4th quartile. We'll just focus there. Adjusted to all risk factors, if triglyceride to HDL ratio is more than 5:1, which does not take much to have that, just give you an example. If your triglyceride is suppose 180 and your HDL is 30, it is 6:1. You're in this category. 16 times higher risk of heart attack or MI, myocardial infarction. We're not talking about atherosclerosis. We're talking about heart attack. Remember, premature plaque rupture in young people leads to ventricular fibrillation or ventricular tachycardia and death because myocardium is not used to ischemia. So next time when we see a lab work and shows atherogenic dyslipidemia with triglyceride to HDL ratio 5:1, we should not ignore it. And there's no treatment. Let me correct that. There's no proven pharmacological treatment. In fact, based on this data, some companies came up with the drugs to improve HDL did not work. Increased mortality was shown in some earlier drugs trials. Medication other than Vascepa that reduced triglyceride does not improve the outcomes. The reason for that is these medications are largely improving your numbers. They're not fixing the root cause, which is hyperinsulinemia, insulin resistance. If you fix hyperinsulinemia and insulin resistance, your triglyceride to HDL ratio will become 1 without any medication. We have discussed risk factors. How about we revisit detecting atherosclerosis earliest? As we know, atherosclerosis starts at very early age. If we define atherosclerosis as intima media thickness of more than 0.55, look at this, teenagers are having atherosclerosis. If this is the definition, it's very strict definition to use. But if the goal is prevention, I think we should be using this definition. And when we find this, we need to start doing lifestyle diet changes much earlier. In 30s, look at that, 60% people having trouble. After age 50, almost all of us have this intima media thickness more than 0.5. This is a very strict criteria, not used clinically, obviously, so we should not be worried about it too much. But if your goal is absolute super prevention, maybe you should look at this data. And carotid intima media thickness percentile chart is available. If you're 95th percentile, you're in trouble. So 1 millimeter is for male, 95th percentile, 1, which is more commonly used rather than 0.5. Younger we are, more should be the strict criteria for detecting this earlier. This is what the normal looks like, and this is not atherosclerosis. This is precursor of atherosclerosis, if we may say that. This is what the abnormal carotid intima media thickness looks like. Anyway, we should focus on more objective data to look for atherosclerosis, because people can have atherosclerosis with no risk factors, zero risk factors. So rather than trying to treat the risk factors, if we find you have atherosclerosis, we can start doing some preventive measures early in life. Risk scoring models such as ASCVD risk score, again, they are surrogate markers. The technology has become good enough that we can detect objective data of an individual rather than relying on surrogate scoring models. Coronary artery calcium testing is very commonly available in US, just for $100 cash, insurance not involved. If calcium score is 0, you have no calcified atherosclerosis. You can still have non-calcified plaque. And coronary CTA, which is very widely available in India. In fact, the cost is very similar to calcium score. In US, CCTA has to be ordered by a physician, and the insurance company may say no for testing. On the other hand, in India, CCTA is like almost over the counter. Calcium score in US is almost over the counter, $100, get it testing done. And this is looking for your objective assessment, whether you have atherosclerosis or not. If you have no atherosclerosis, great, continue working on risk factors. But if you do have proven atherosclerosis, you have to do more than just working on risk factors. If your calcium score is 0, great, as long as you're asymptomatic, but let's look at this data. We can predict, once we develop a calcium score of more than 0, how the progression of atherosclerosis is going to be 10 years later. Some people, maybe from risk factors, family history, we develop early coronary atherosclerosis, mid-30s. And progression is a lot quicker in 50s and 60s compared to when we develop atherosclerosis later in life. Higher coronary artery calcium score, higher is the risk of sudden cardiac death. Calcium score 0, low risk of sudden cardiac death. Calcium score more than 1,000, very high risk of sudden cardiac death. Linear relationship. In fact, calcium score more than 400, newer data coming around maybe 300, should be treated similar as the person already had MI in terms of preventive measures needed. Calcium score more than 1,000 is really bad. So this is sudden cardiac death event-free probability or survival curve. So lower is better. Calcium score is 0. Next 10 years of surviving is very high. Look at that. Very low risk of dying. But if the calcium score is more than 1,000, very high risk of death. And next, look at this. Next 5 years, 10 years, very high risk of death. This is not to scare you, but take preventive measures. And the discussion is incomplete if we do not talk about LPA. LPA has been well recognized risk factors for a while, but more and more data is coming now that it is getting recommended that we check LPA at least once in everybody. If you check your LPA, it's abnormal, it's going to be abnormal for long term. There are some new medications coming to address that. But if your LPA is normal, you do not have to check it again in lifetime. But this interesting data I think we should discuss. If we have low attenuation plaque, which can be detected on CCTA, coronary CTA. If you have high LPA and we have presence of low attenuation plaque, 4.6 times higher risk of MI as compared to if your LPA is normal and you have no low attenuating plaque. And it's graded relationship. The higher is the LPA, more is the risk of MI. I see this confusion all the time. I think we should address this. Zero calcium score is really good information to have in terms of having low risk of events in future. However, it is for asymptomatic person. So if somebody has any symptoms which could be attributed to coronary artery disease, we cannot rely on zero calcium score. In fact, this is an interesting paper. You can go and read the full paper yourself. People who had symptoms and who had zero calcium score and the CCTA was done, look at the data. Some people had obstructive plaque and some people had obstructive plaque in all three vessels with zero calcium score. So zero calcium score is great for asymptomatic person for risk stratification, but not for symptomatic people. Do not rely on calcium score of zero if somebody has symptom, even though it's very atypical symptom. Get the coronary artery calcium, get the coronary CTA done to assess if they have plaque. If they do have obstructive plaque, obviously a lot needs to be done. If they have mild plaque, medical therapy, even moderate plaque, medical therapy is good enough. Scott Hart study is an interesting study. I wish it was like India Heart study, where this study was done on Indians. Would have been so nice to have data on us rather than going for Caucasian data and kind of extrapolating what we should be doing based on Caucasian data. Anyway, let's revisit this. I think this is important study. So in this study, 6,000 people were randomized 1-to-1, and if the assigned score was less than 10%, only lifestyle modification was recommended. If the risk was more than 10%, it was recommended not only do lifestyle adjustment, start statin therapy. And the other people were randomized into CT coronary angiography. If it was completely normal CT coronary angiography, just the lifestyle advice was given. If they have obstructive plaque, much more intensive treatment was given, and referral or review by cardiologist was recommended. And non-obstructive plaque, lifestyle changes, lipid lowering therapy, and antiplatelet therapy, largely aspirin, was recommended. And the primary outcome was composite of death from CAD or non-fatal myocardial infarction. I think both are important endpoint that we as a clinician or somebody as a patient cares about. And secondary outcomes, I'm not going to review that much. So let's look at the data. This is eye-opening data. Case example 1, 47-year-old female, smoked in the past, known hypertension, so she has risk factors. Assigned score 3, low, lifestyle advice was recommended, great. CT angiography showed non-obstructive disease in proximal LAD. Non-obstructive disease in LAD goes in this category. Patient not only needs lifestyle advice, needs lipid lowering therapy and antiplatelet therapy to reduce events. Again, this is data for Caucasians. I wish this was a study for Indians. But we get atherosclerosis at much lower risk factors compared to Caucasians, so we should assume our scenario worse than Caucasians. Let's look at the case example number 2. 68-year-old gentleman, hypertension, type 2 diabetes, dyslipidemia, atrial fibrillation, assigned score crazy high, right here, 34, but objective data, look at this, normal coronary arteries. This person is in this category actually, even though scoring system is telling us this is a very high risk patient. So despite risk factors, this person had excellent endothelial cell for some reason. Could be genetics, could be something else, we do not know. I wish we had better answer for that. But this person does not have to worry about MI and those things because patient does not have atherosclerosis. Let's look at the example number 3. 62-year-old male with hyperlipidemia. Mild risk factors, assigned score is 11. So somewhere in between, maybe, yeah, lipid therapy, 62, dyslipidemia, so lipid therapy, maybe statin and aspirin. But look at what coronary CT angiography demonstrate. Obstructive disease in left main. This is the highest risk person for sudden cardiac death. And this is one of the reasons I do not want to rely on risk scoring model when the technology has evolved enough that we can look at the objective data of an individual. As a cardiologist, I will recommend this patient gets either bypass or PCI. I will not recommend this person to continue medical therapy only. So did coronary CTA change the outcome? Based on the examples I gave you before, what do you expect the results of the study? Look at this data. In the CTA arm and standard of care arm, the curve separates quite early. Death from coronary artery disease or non-fatal myocardial infarction curve separates very early because CCTA, if we find left main disease or severe obstructive 3-vessel CAD, obviously you're going to get revascularized. And I'm guessing that changed the outcome as compared to standard of care. The curve keeps on separating as the time goes by. Similarly, non-fatal myocardial infarction or any heart attack also reduced in CTA arm compared to standard of care arm. And this is subgroup analysis. I mean, we should take any subgroup analysis with a pinch of salt, but kind of interesting data to see here. Left-hand side coronary CTA is better, right-hand side standard of care is better. Irrespective of age, calculated risk factor scoring, typical atypical chest pain, diabetes, CTA is better. In females, not much different. And if you have prior history of coronary artery disease, obviously CTA not going to change the management of anything. We already know you have disease, so you got to be doing something else. So look at this. Anytime with the curve, the line crosses 1, there's no difference between these two. Anyway, so let's focus on more important thing. As Indians, we are plagued with atherogenic dyslipidemia, right? We don't get very high LDL. We get low HDL, we get high triglyceride, we have a little bit of belly fat, thoda sa पेट निकला हुआ है. We get fatty liver at much lower, thoda sa पेट निकला हुआ if we do FibroScan or ultrasound. And so many of us have lipoprotein pattern B. When I ask my friends to get this NMR lipoprotein analysis done, completely normal person, lipoprotein pattern B, which is very disappointing when I see this. And remember, lipoprotein insulin resistance from very first few slides, 6.5 times higher risk of MI compared to 1.4 times higher risk of MI with high LDL. Do not just focus on high LDL, please. Focus on lipoprotein insulin resistance. If you have lipoprotein insulin resistance, we can fix it. And let's assess how we're going to do that. Before I talk about more data, I think this is important knowledge to have because sadly most physicians do not know this. When we talk about lifestyle and diet changes, all of us have very strong opinion about diets without having good understanding about data. So let's understand this. This is very, very critical for us to understand. Most of the studies which are nutritional research is based on what is called food frequency questionnaire. I'm not sure if you've ever filled any food frequency questionnaire yourself or not, but if you have not, I would strongly advise you to do a self-experiment. After I did this self-experiment myself, I stopped paying attention to any research where the method is based on FFQ or food frequency questionnaire. The self-experiment is this. I would like you to make a prospective diary and write down everything that you're eating for 1 week, from starting from breakfast to last dinner. And after 1 month, I can give you this FFQ questionnaire available online. If you want, just Google it, download it, and fill that FFQ recalling how you were eating before. And now compare this prospective diary to your recall. You are a physician. You are supposed to be one of the most educated person in the society. If the data you got is completely garbage, that the person of higher IQ in the society compared to average people are getting such bad recall, how can we trust on any information coming out of food frequency questionnaire based research? Although people who have made career out of this, they will say this is all well validated. Yeah, sure, it is well validated, but it's completely junk data. It is largely garbage in, garbage out. Please do not base your opinion about diet based on FFQ based junk publication. A lot of this early publication are coming from very famous East Coast Institute, which is very sad. Anyway, RCT is the best way to assess cause and effect. It's very expensive. It is not possible for us to do this for humans. I mean, our diet is not just based on health, it is based on cultural aspect of things, and it's difficult to change your diet completely. But anyway, we should rely on randomized controlled trial data. There are plenty of them published in very reputed journals actually, as compared to relying on food frequency questionnaire. I hope I made this point very clear. This is how I personally fixed my own insulin resistance and atherogenic dyslipidemia that I had. Like I mentioned to you, I went to a very famous preventive cardiologist that said, your LDL is great, don't worry about this. And I was like, what do I do about my low HDL? Even though I'm running 5K every day, I'm doing everything by the guideline, I'm eating plenty of fruits, vegetables, nothing is happening. But when I came across this NEJM RCT data, I was shocked that how come we do not talk about this. So let's visit this. You can go to this trial data yourself and you can read the full detail yourself. My focus is two things, is improvement in HDL and reduction in triglyceride, because that's what we get as Indian most of the time, right? So conventional diet is, you know, the heart healthy diet that we promote. And low carbohydrate diet, you can read the data yourself, what the definition of low carbohydrate diet is. So when the low carbohydrate diet was started, look at the change in triglyceride, dramatic improvement in triglyceride. Look at the improvement in HDL, way better than any exercise can bring you that. So if you have insulin resistance, if you have lipoprotein insulin resistance, if you're having atherogenic dyslipidemia, you can look at from this randomized control trial data, of which diet you should be following yourself. And here they will tell you at 12 months differences. In conclusion, difference is not much, but again, if you read the paper carefully, you'll see the more carbohydrate was added, and therefore they had this weight gain. Even though I'm more interested in this, not weight gain as such, even though the carbohydrate was added later on, triglyceride remain low, HDL remains high, but HDL is downtrending again. Look at this. When you increase the carbohydrate intake in diet, and our diet is so rich in refined carbohydrate, even complex carbohydrate is not good enough. You have to restrict the carbohydrate intake dramatically in order to improve your HDL like this. And you may see even more dramatic effect than in randomized control trial if you can do it very strictly. So you may say one trial is not enough. I agree with that. Let's look at one more NEJM paper. So here they compared low-fat diet, which is American Heart Association has been promoting for several decades, and I do not agree with this low-fat diet nonsense. Anyway, they compared that to Mediterranean diet and low-carbohydrate diet. Remember what we're looking for, treatment of atherogenic dyslipidemia. What happened to HDL when you cut down the carbohydrate? Look at that one more time. One more randomized control trial demonstrating this. What happened to triglyceride when you restrict the carbohydrate? Dramatic improvement. Again, in this, carbohydrate was added again, and look at what happened. It is better than Mediterranean diet. LDL does not differ much. As a cardiologist, first thing that comes in mind when I start telling people about low carbohydrate, the first thing they say is, oh, your LDL is going to go crazy high. Not the case in randomized controlled trials, but obviously it needs to be very carefully reviewed on follow-up. There are multiple other randomized controlled trials. For the lack of time, I'm not going to add that, but you can search it yourself, publish in very reputed journals. So I would like to conclude this talk with the following take-home message. Please and please keep your endothelial cells healthy. That is the most important thing you can do to not have atherosclerosis. And how we can keep endothelial cells healthy? By being highly insulin sensitive. And how can you check whether you're insulin sensitive or not? Get the fasting insulin level, get the fasting glucose level, keep your HOMA-IR level less than 1. You can just Google the calculator, put the number in yourself and see where it is. And how can you have HOMA-IR less than 1? Lifestyle. You got to have moderate physical activity every day, minimum 30 minutes of brisk walking. The walking has to be at a pace that makes you short of breath, that you're not able to complete one full sentence. If you do a stroll like uncles do in Indian park, it is useless. It is not having much cardiovascular benefit. In fact, if you're walking briskly or jogging or maybe running, GLUT4 receptors wake up, and your muscles becomes more insulin sensitive actually. And weightlifting is very important. We Indians are sarcopenic, even as teenagers are sarcopenic. We have sarcopenia because of genetics, because of diet, maybe because we don't lift weight. So start doing some sort of strength training, weightlifting exercise, and gain some muscle. It does not have to be a lot, just small amount of muscle gain. And then on top, you have to change your diet. You cannot be highly opinionated about diet and have lipoprotein insulin resistance. In randomized controlled trial, it's been clearly shown that low carbohydrate diet improves your insulin resistance. It improves your triglyceride. It improves your HDL dramatically. So focus on that. And we must try to achieve triglyceride to HDL ratio less than 2:1. Ideally, it should be 1:1. Very, very difficult to achieve this as Indians. And more important is, just know if you have atherosclerosis. Do not rely on ACVD risk score that is designed for Caucasians. And Scott Hart data is very clearly showing the score model is not as good as getting direct data. If you want to be really, really, really cautious, even though as a population, on the population basis, we cannot make this recommendation. We cannot just say that everybody should get coronary CTA. It's not possible. If we look at this from policy making perspective, it is just not feasible. But that is the most objective way of assessing if you have coronary artery disease. If you do find you have coronary artery disease, right medication can stabilize the plaque. And once the plaque is stabilized, you're not going to have MI. That's what matters. How people die from atherosclerosis is from MI largely, or that's how we get the stroke, or in the leg we get cold leg and amputation of the leg and those things when we have diabetes. How can we stabilize the plaque? Remember that thin cap fibrous atheroma, 65 microns. If you can make the 65 microns to 200 microns, you're never going to have heart attack. The STEMI one, the big heart attack. How can we stabilize the plaque? It is the ACE inhibitor ARB that stabilizes the plaque. It is not the beta blocker. It is the statin that stabilizes the plaque. PCSK9 inhibitor definitely stabilizes the plaque based on invasive data. Unfortunately, we do not have any non-invasive tools available currently to see who has thin cap fibrous atheroma, which is very sad. I mean, you have to do very invasive angiography, put the wire across and do optical coherence tomography, OCT as we call this, to know who has thin cap fibrous atheroma. Highly, absolutely not recommended to have that kind of invasive procedure to have this data. But AI is evolving quickly. They are finding that AI can recognize the pattern better than us. So if they one day they feed all the data to some of the models where CCTA itself can predict who are the people who are going to have MI based on the plaque composition, that data will be coming in few years. That would be great to have that data. So lifestyle changes, diet changes, and if we do find you have plaque, stabilize the plaque and live a normal healthy life. With this, I would like to conclude my talk. Many thanks to FMC.